Welcome, everyone, to the Healthcare Crossroads. We are so excited to start this new podcast, just really showcasing healthcare data compliance and patient care. And we have many that we're bringing together in this episodes to come this season. Especially today, I have one of my favorite people on the show, Betty Hovey. Welcome to the show, Betty.
Hey, Jennifer. Thanks for having me. Very excited to be here.
I am so excited to have you here, Betty. And it's been, of course, a little bit since we've been on together on the show previously, but I think it's going to be a great show today when we can kind of get back into talking to each other. And we
Yes.
have some new listeners since the last time you were on the show. So let us know a little bit about yourself, how you got started in healthcare, what you're doing now, and what led you to this world of auditing.
Well, I have been in the field I hit my 35-year mark this year. So I've been doing it for a little bit. I started out as an X-ray tech and learned that, the touchy-feely stuff wasn't, so much my bag. Worked at a hospital that was not officially the county hospital, but was kind of the county hospital, so we just got everything. We had the prisoners from Stateville, which was the largest prison in the country at the time. So we would get some lovely individuals that would come in that we would have to, work on. Had to work on some dead bodies, and so I was just like, yeah, no, it's a bit too much. So I went to the health system. I was just like, I don't want to do this, and so they said, well, oh, we have a great job for you. You have a medical background and terminology, and so they set me in a room for 2 weeks with the CPT and ICD-9, because that's what we were on back then, and a HCPCS book. And so I sat in there. I came in every day. I sit in this room all by myself. I'm looking at these books and I'm like, okay, and then at the end of 2 weeks, they came in, they took me to my desk and said, okay, your training's done, get to work. And I was like, oh, okay. So back then, in the 80s, we didn't have, there weren't really a lot, we didn't have a name for what we did. It wasn't really considered a profession like it is today. So we would look at things and just be calling each other to try to say, well, what do you do with this? And how do you do with that? And, I was pretty good at CPT because as an x-ray tech, you're all about body parts, and so I could find things in CPT. But ICD-9, oh, I hated it because you look at a body part and it would say C condition. And I just used to drive me crazy. But back then, if I couldn't figure out an ICD-9 code, we could actually send a claim with no ICD-9 code and they would pay it because you didn't have to have one. Now, of course, we do, so we have to show medical necessity and all that. But going through that really kind of spurred in my head, if I'm having these kind of troubles, I can't be the only one. And I used to get calls from people from other clinics for the same stuff. Like, where did you find that before? And so we'd make our little job aids because, I don't like calling them cheat sheets. So we'd have our job aids that we'd pass around, and it led me into the educational part of things. And I got into AAPC. And I said, I took my exam again back in the early 80s. And I am such a long time member that my membership number has like 4 zeros in front of it. I mean, that's how far back I've got my membership. And from there just started to do education and got more into the auditing part and things, and just expanded, had my company started, and just moved into the auditing and education side of it because that's really where my passion kind of comes in. When I'm working with the physicians, I shadow physicians. I love shadowing physicians. Going into the patient rooms with them and kind of watching what they're doing, and then we discuss it after they get out of the room at, okay, what level did you think that was? And let me see your documentation. And you get them right then, and so it sticks in their heads better. um, and they love it. They love having you there to, oh, and what about this? And what if I said that? And I just love that interaction. And same with the staff and the coders and the auditors. So that's really what excites me about doing these things. And now that, thanks to COVID, we all have the virtual things that we're getting into and doing, so we can actually expand the audience base to hit more people, which is very exciting because I love doing in-person live things, but I also like these kinds of things because we get to talk to people in other countries and in other states. And, whereas if you're doing the things in person, unless somebody's flying in to see you, it kind of limits that, so we can actually expand our bases, which I think is very exciting. Um,
Mhm.
and I have my broadcasts that I do. They're called Healthcare Happenings. I
Yes.
do them on Thursdays. I call them Baby Fridays because that's we're getting ready. And tomorrow I have one, and it's on the global surgery package. And Christine Hall is my guest. I'm sure
One
you
of my
and your
favorites.
listeners, yes, I know. I'm sure they all know Christine. So anybody that wants to, get notified of my broadcast can follow me on LinkedIn, and they'll get notices. And my new exciting news is that the lady that I work with for my IT, her name is Patty Hernandez, and her company is Fired Up Creative. She's wonderful, and they're turning the broadcast. They're going to do the podcasting for me. So soon, my healthcare happenings will be available as podcasts. So I'm really psyched about that.
That's a lot. Oh my goodness. I'm excited for all the things that are going to be happening for you and then all the things we're going to get to benefit from, as, of course. You've been team for a long time. I started a year ago with the hospital I was working with, so internal audits. And then in 2020, I wasn't sure. I was similar to you. I had my business going. I was doing all this stuff. And then I decided that I didn't want to do that anymore. I wanted to have a more team environment. I wanted to see if I could be a consultant and go into consulting and education full time. And so that's what I did. And it's been a nice transition with OncoSpark, just being able to just be a consultant, be an educator. And that's all I do. But it's not all I do.
Yeah,
Obviously, there's more to it. Learning how to develop these things as a team and collaborating with others like yourself is really what really makes a company thrive, which is why
yeah.
we're here today. We're here and about auditing. So, for instance, ask a question: why do we audit, Betty? Why is this an important thing for us to do?
Well, I always tell people when we talk about this is that you want to do it yourself before somebody else does it to you. So, you want to make sure you're looking at your records, looking at your documentation, making sure that your physicians and other providers' documentation is where it needs to be to support the services being billed, because the audits coming from the payors is not going away. It's just getting more and more and more. So better and fix it before they find it, because they'll find it.
Yes, they will. Oh my goodness. And we've had, other collaborations with other auditors out there. We all watch the Chuckleheads podcast and we watch
Yes.
this weekly podcast that Sean Weiss has with Christine Hall and Terry Fletcher and others, where they talk about these audits and these crazy things that they're discovering with
Yeah.
these providers and clinics and facilities getting in trouble all over the place for these, to me, unnecessary things.
Yeah.
Very
Yeah.
unnecessary. But we see that we understand the reason why you audit. Now, you have a compliance plan, you have to have some kind of system in place where you're checking accuracy and consistency of data. And then, of course, whether it's internal or external, I think a lot of people miss the external part, which is what we are, right? You and I
Yeah.
are external auditors. So, why are
Yeah.
external auditors just as important as internal? And then another follow up question: do you need to have internal? Um, can you have an external audit without doing internal audits? What is the purpose of each of those?
Yeah, I think the misnomer, or the mistaken idea, is when the um, government suggests you do internal audits, that people practices sometimes think internal means their own employees. But and there's nothing wrong with that. A lot of times you can have internal checks and audits to kind of spot check and target certain things, or to help a physician or provider that's having an issue. But having an external audit, someone from outside come in and do it, I think gives that layer of, um, you know, where the internal person, in fact, on the Sean's broadcast yesterday that you were talking about, or Monday that you're talking about with Terry and Christine and those guys, I had made a comment that he read that I went into a practice that had gotten, they were in a little bit of trouble. And when I looked and they said, but all of our audits have been great. We don't understand why these payors are now asking for all this money back. And I said, okay. I said, well, who was doing your audits? And they said, well, our coder was doing them. And I said, well, do you mean the coder that does your coding is auditing her coding? And they were like, well, yeah. And I was like, well, do you not see an issue with that? So she said she was great, but the
Yeah, of
payors
course you
beg to
did.
differ, so, and the other bad thing was when this started to happen, she left. And so now they were like without anybody. And so I said, well, so you need to have, um, somebody that's not got skin in the game, who's not worried about their job, who's not worried about telling the physicians or providers, hey, maybe you're not doing this so good. And I'm not saying that all employees that do these things would do that, but some people that's got to kind of get in their head maybe a little bit, and they know their doctors. And so sometimes they'll look at a record. How many times have you seen this, where, you're in there and they say, well, I know that's what they mean. Okay, well, that's what they mean, but an outside auditor is not going to give that deference to them. It's got to state it. And so sometimes the internal people kind of give a little bit more credit than an outside auditor would, that would kind of say, hey, no, you really need to be clear in your documentation on this, because while you know what you mean, somebody else might not, that's from the outside. And so it really needs to stand and give that information. So I think it's important to have that, nonpartisan kind of third party looking at things, to make sure that you're on the right thing. And then you really have an external auditor that is usually, not always, but usually more experienced than your internal people. They've, because this is what we do, and that's, we have like that broader base of knowledge, and we've seen like, oh, I've seen this with my other clients, or I've had seen this from one of the payors where they're starting to look at these things now. So you can give that practice that kind of perspective of that more broader based things that their internal person might not be seeing. So that's why I think it's really important to get that. And it stands up better, I think, if a payor is coming in and you can say, hey, we've had an external auditor look at these things, and this is what their recommendations are. Sorry, there's a plane going overhead. Wow. Okay, that sounded close. Could you hear that?
I could, yeah, it's crazy. Well, yeah, that happens.
So I think it kind of stands up a little bit better with the payor to say it was an outside, expert that we had look at these things, and they're agreeing with, what we've been doing, or, we're getting some outside education to help us, or, whatever that case may be. I just think it's really good to have that nonpartisan third party look in at things.
Absolutely. And I know we had planned to talk about certain types of audits because organizations need to know about these different types of audits. Most of them do know what their
Yes.
data hopefully is telling them, but that's the purpose of an audit, right? Is to really discover what your data is telling you.
Yes.
Because data doesn't lie, numbers don't lie, as we know. So
Right.
let's talk about the different ones: random, targeted, and then retrospective and prospective. Go ahead and give me a little bit about these different ones from your perspective as to why we do these different types.
Well, I think the kind of audit you're going to do, and that's the other good thing, you can do different kind of ones internally and then have different kind of ones externally. So you can kind of spread and get more things, hit more bases. Um, but with the retrospective audits, you're looking for things that have already been paid. So you can get a broader base and look at more data and have more time because it's already been paid. Whereas with the prospective audits, you're doing them before they go out, and which in one way is really good because you're catching anything that may be an error before it goes out. So you're getting a clean claim that goes out. But the problem with doing the prospective audits is that if it's a large facility or a large practice that has a lot of physicians, you can't hold their claims up for that long. So it really gets to be where it's not something that can be done on a larger scale basis. You can't check every single encounter that the physicians do if you have 40 physicians or even 10 physicians, 5 physicians in a practice. It's just too hard. um, but it can, it can help with spot checking different things. And if you're looking for targeted things, let's say, well, we're going to prospectively look at level fives. So any level five, before it goes out, we're going to have the coder take a look at it, or modifier 25, before those go out, we're going to have somebody take a look at them and make sure that it looks okay. So for prospective, it's kind of good to do for things like that. Retrospective, as I said, you can do them random where when I do a baseline audit, I like to try to do for a new practice, or they've got a new physician coming on or a new provider and they want a baseline on them. You can kind of just take random things just to kind of get pieces of and see if you find anything. You can do them where they're targeted to, like I was just mentioning, like let's look at fours and fives, or let's look at new patients. Let's look at,
Right.
specific procedures and things. And then you can gather data from whatever your time frame is, and say, okay, we're going to go from the last 3 months. I don't recommend going back a year. You're asking for trouble for one, I think, if something comes up. And you know the guidelines and what payers are doing and all those things change so much that
Mhm.
going that far back is just, it's not going to benefit you. So usually I try to do like a 3 month or quarter. I don't really like to go further than that. Um, and then you can say, okay, do we want to do this random? Are we looking just for E&M? Do we want E&Ms and minor procedures? Do we, and then what I like to do is I have my clients run a CPT frequency report. So they run it by each physician and provider and see, okay, what are the main things they're doing? And then we say, okay, well, then that's what we're going to do the audits on. Now, we can pull a random odd thing if they have a question on it, but you might as well spend the time on the things that they do most. That's what's going to benefit them the most. So when you're looking at doing them, so I kind of do a random targeted, if that makes sense, when I look at
Yeah.
things. Now, I also use rat stats when I do them. Rat stats is a government software, and anybody listening can get that. You can just put in rat stats and Google it. I love when you put it up and you download it, it's got that rat. It actually has a big rat on the icon.
Is
So
that funny?
but what it does is it allows you to put in however many things you're looking at. Like I've got, from the last 3 months, this provider has, 800 visits, or 800 encounters, and I want to do, 10%, or I want to do this, and then it randomly chooses numbers for you. And that's what the government uses. So if you're using the same stuff they are, then, if again, you get something from Payor, you can say, we used rat stats to pull this, so it's truly random and it will be accepted. So that's the
Cool.
good thing. And then I just start pulling from there.
Mhm.
Depending on my clients, some of them I will go into their systems. I'll dial right in so we don't have to be sending records or do any of that mess anymore. Some of them don't like that, so they will, gather the records and then send them electronically. Some of them do still prefer the old route of sending them, hard copy in paper, and that's fine. So, anyway, as long as you've got the whole record, that's the thing. When you do them and they send you the paper charts and they pull it, they may be missing certain things that, you may need. So it kind of drags the process out a little bit longer.
Mhm.
Um, but that's kind of how the process runs, or how I do it when I'm doing the processes for my clients and the different
Right.
types that we look at. So I just kind
Absolutely.
of, have a phone call with the clients, see what they're actually needing, and then
Yeah.
talk about how many records, because you have that whole conversation, right? That it's like how many charts are enough,
Right.
and sometimes they want the five. That seems to be like a number that people are, oh, well, five's good enough. And if you have a lot of providers, a lot of physicians, five may be, what's workable for them. But I always tell them, well, just consider though, with five charts, if you have one that's not correct, your percentage is not going to be meeting that 95 to 98% that the government says you should have. So you're immediately looking at,
Yeah.
depending on how your compliance plan is laid out,
It's a
you're
good point.
immediately
Yep.
looking at maybe some issues. So I
Yeah.
try to get at least 10, because it does give me a good idea sometimes of what I'm looking at. And with the
Yeah, we do
way
the
that
same.
guidelines are set now, at least for office visits, I know next year it'll be all of them. You really can get a good idea off of 10 records about, where their pain points are for things, and where you need to give them education. For new physicians and providers, I like to do 20,
Mm.
because then it gives me a bigger thing to say, okay, well, they're doing okay here, or here's where we need to do a little education and kind of get them on the right track, and,
Mhm.
stuff like that. So that's kind of, how I look at it, and the different kinds of audits, that we perform.
Wonderful. And I do have a question from Miss Annette Bush on LinkedIn. The LinkedIn feeds are not coming through here for us, but I wanted to pull this for us so we can
Great.
chat a little bit with our audience. What's the best resource to know what payers are auditing?
Oh, well, there's all kind of resources that you can look at. Most of us, and I don't know, Jennifer, if you use some different things, but a lot of us will go off of the OIG work plan is
Mhm.
a good
Yep.
place to look and see, because now they update that every month. There's always new things coming on there, so you can see what the government is looking at, what the Office of Inspector General is telling CMS. Hey, y'all need to pay attention to this. Um, the CERT reports, the comprehensive error rate testing reports, those will come out and say, hey, the payer should not be paying these things because we're finding documentation issues. Again, it gives, Medicare, oh, then maybe we need to go look at these. So if you're doing a heavy Medicare based population, or your payors follow Medicare guidelines, looking on what CMS is looking at will help you in what you're looking at.
Mhm.
Also, they have um, the CBRs, the comparative billing reports that will come out, and they do those every month. Every month, you can go and look and see what the current CBR is that they've put out, and what those are is those are notices that get sent out to whatever they're focusing on for the month, in case you're an outlier. So they'll
Mhm.
send you a little letter and say, you don't have to do anything, and we're not saying you're getting audited, but we just want to tell you, just so you know, you do a lot more of these than anybody else does. So, it's kind of to let you know that it's something you should check out. So if you get a CBR, then you want to make sure that you do an audit on that specific thing and see why you're an outlier. There may be a good reason you're an outlier. Maybe you're the only specialist in that geographic area you're in that does this type of thing. And so by
Correct.
nature, your patients are going to be having more of these types of services, or be higher level. So there may be a good reason for it. And if there is, great, then you don't have to worry. But if you get one of those letters, make sure you're taking a look at it.
Exactly.
I've been in offices where I had a physician, well, yeah, I got this letter and it said, I was using the modifier 25 a lot and blah. And I said, well, where is that letter? Oh, I threw it out. Uh, yeah,
Yay.
I'm like,
Good
please
job.
don't do that. It's, so anytime you get a letter from a payor, you want to make sure you go through it and that it gets to the right people. Um, or you get the take back requests, because that's what's coming next if you're ignoring these things. then they're going to want something back, or they're going to start asking you for records, or they're going to put you on prepayment review.
Hmm.
But those are some of the places I would say, you want to go to kind of see what they're taking a look at.
Agreed. Now, gonna just jump right in because you did mention modifier 25, and my next question was audit risks. And I've talked till I'm blue in the face. A lot of us have talked to her blue in the face since 2005, since
Yep.
the OIG came out with their report on modifier 25. It's not getting any better. Same with
No.
modifier 59, not getting any
Yep.
better.
Yep.
I did a webinar recently, and we had 600 people on this webinar that wanted to attend this webinar about modifier 25, because it's not just, the physicians want to know, but also there's just so much confusion about it. And every specialty is different, right? With how
Yeah.
you would interpret that. And every documentation stands alone. And we have to understand, first and foremost, you're asking for more money when you append a 25 modifier.
Yep.
Do you think the insurance company is just going to shell it out without looking or making sure that they're paying for it appropriately?
Yeah.
59, you're asking for more money because you're asking them to pay for something that is normally bundled into the other procedure you're doing. And now you're
Yep.
asking them to unbundle it and pay you more. And
Yep.
so, again, they're going to ask why. And they're going to want to make sure that you have followed the guidelines. I mean, business 101, just going back to it, any business that, you have a service with, they're not going to pay you money until they confirm the service was performed. Now, in,
Right.
in healthcare, there are times where you submit a claim, it gets paid, no one questions it at that point in time. But what happens
Yep.
later, right? So, Betty, give me some insight in here. What are you seeing, and just an overall perspective of these modifiers? What are you seeing?
Yeah, modifier 25 is definitely on the increase as far as reviews by payors. Um, it was on the OIG work plan for dermatology specifically. They called dermatology out, and said that they were looking at it. And there are certain specialties, and dermatology happens to be one of them, where you get a patient that comes in a lot of times for derm. A patient will come in and they're coming in because they have a lesion on their arm, and then they get in there and say, oh well, I also have this and I have this, and they want everything done today because they don't want to come back. They just want to come once a year, have you do everything under the sun that you can find on them, and destroy it or shave it off or what. They just want it all done today. So you have a lot of cases where they do use modifier 25 a lot. And like I said, as long as the documentation supports it, then I always tell my clients, hey, you deserve that money, you get the money, but you have to make sure your documentation supports it. And the whole thing with modifier 25, as you were saying, Jennifer, is that it's that significant, separately identifiable, and you have to remember that when you're looking at it, if you have the two different diagnoses, you're kind of, those are kind of no brainers. With they came in and I had this done to them, but they said, oh, by the way, or when I examined them I said, hey, what's that? And then we got into this separate discussion. It's in your documentation though. They have to make sure that those oh, by the ways, you document that. And while the patient presented for this, while they were here, they also stated, and then show that separate work that you did on it. And if you just think about that, it's separately identifiable. So what I do when I'm taking a look at this is I say, okay, every E&M or every procedure code has a little bit of E&M bundled into it, because they know that no physician will or should, just walk in and say, give me your arm and just start, shaving stuff off. They're going to ask you, is it bigger? How has it changed? Let me take a look at it. They're going to talk to you and then explain what they're doing, and then they're going to do it. Well, that's E&M, right? That's part of that procedure. You don't get paid separately for that. It's part of it. So in order to get paid separately for an E&M, you have to go over and above that. So when I look at documentation, I look to see, okay, this is part of that procedure, talking to them about that lesion on their arm, the examination of that lesion on their arm, all of that stuff gets pulled down into the procedure. And then I look for what's left, and if there's not enough left in the note to support an E&M, then, they don't get it, that's kind of, I think that the hard part is that people forget that part of detracting away the portion of the E&M that belongs down in the procedure. Because yes, there is an E&M there, but what's the E&M for? And then, especially if they're scheduled for the procedure, I see this a lot. Patient presents for lesion removal or for whatever the minor procedure is. And then you talk about it. So it right off the bat, it's saying they're here for the procedure. They're not here for evaluation. If they present for a procedure and all you do is that procedure, that E&M portion that you're talking to them about it is definitely bundled into that procedure, and you do
Mhm.
not get a separately reported E&M.
Agreed. Now, you mentioned minor procedures. Now, in my world, orthopedics, and I'm also a consultant for ophthalmology, we do
Mm-hmm.
injections, right? So
Mm-hmm.
it's always been a huge issue, an audit risk with these injections, and not just necessarily the modifier 25 issue. It's really just in general the medical necessity of things, and it's
Yeah.
are all the pieces needed. Do you have all the pieces needed documented to support this injection? And it's the units, it's having the NDC number, it's knowing the payer requirements and coverage guidelines, and
Yep.
all these pieces go into it, which is why I think a lot of providers or facilities just don't have a good understanding of these things, and so they have all this staff right on, and they're all getting it wrong, unfortunately, because they weren't trained. And then you're
Yep.
paying all this staff, you're not getting reimbursed to cover those costs, and this is why we're in the problems we're in right now, because you have
Yeah.
all these staff members doing these jobs that they're not trained to do, and so then you're shelling this money out to this job that's not bringing in the money. So
Yeah.
that's why we really push audits. We push education. Do you find often that when you do these audits, that you have clear now a clear look at where the education needs to be now? Is that an important piece to the audits?
Definitely. I always, when I do audits, excuse me, and I contract with physician practices, that's part of the audit. The audit always has to come with a report and findings, and do the follow-up calls, and then set up education as necessary, because it doesn't do any good to keep telling somebody they're doing something wrong without telling them how to fix it. So yeah, you definitely have to educate. And the education, as you were saying, is not just always for the physician or provider. It does stretch out to their staff, because in some practices, the physicians choose their E&M levels, maybe, but they don't choose all of the codes. And there's coders that are in the office or someone in that role, that looks over things, that maybe, doesn't understand all the things they're looking at, or doesn't have what they say, well, I don't have time to go to the payer sites and look for this or look for that, because there's so many, they're doing 6 jobs, at once. Um, and so they need help with those kind of things to say, so when I do my audit findings, in every audit I do, I give an executive kind of report where it's kind of like the highlighted thing, and then I give the detailed report. And in the detailed report, I have a comments column, and it's in there, well, I'll put, according to the CPT manual or according to the payer for this claim, in their provider manual, it says on page 4 that, you can't do this, because that's one thing when I talk to the staff, and I'll say, well, what does your policy say? What does their policy say on this? Or what does your compliance plan say about this? Or your internal policies? They're like, I don't know. And I don't, yeah, they don't go to the sites and use those, which is another good reason to look at external auditors too, is
Hmm.
because of, that factor. We put that extra time in that maybe an internal staff member might not have the time to do. But there's
Hmm.
a lot of really good staff that if they're given the education, would be able to run with this stuff. But,
Absolutely.
they're on the job learning and there's not time to do it, or the person that was there is gone. So they're coming in with nobody to help them. And it's just like, oh, well, yeah, you can figure it out. Back in the day, we'd have people that, you're filing charts one day, the next day they're like, oh, yeah, you can do the coding. Here you go.
Yeah,
And
it's
there really
easy.
wasn't a big thought process because they didn't pay attention to it. And now they're getting that that's the financials of the practice. If you don't have somebody that knows what they're doing in that position, you're not going to be able to keep your doors open.
And we're seeing the results of that since 2020,
Hmm.
even before, but it's come to a head right now. We see a lot of the problems here, staffing shortages, and going back to just in general looking at coverage guidelines. I want to talk about this for just a second because you work in plastics like I do, and
Hmm.
you've had this experience. And I always preach this about coverage guidelines because you can get a procedure code covered and you bill that procedure code. That's great. You coded it correctly, right? But you didn't look at your commercial carrier, Blue Cross Blue Shield, for instance, doesn't cover that product. And so I'm talking about in plastics, we have these grafts that providers put on, on a patient during a
Yep.
breast procedure, for instance. And the 157 code comes to mind. It's covered
Mhm.
and it's a billable code. Great. You coded it. But you didn't look that the product they were using is not covered by the policy and now you're not getting paid. Even though you chose the correct code, you got it authorized, no money's coming in.
Yep.
And it also affects your facility, right? Your ASC, who also can't get that paid. So
Yep.
again, these are conversations I've had when I'm auditing and I'm discovering this, and our staff is discovering this with the providers. And we have to make our recommendations. At the end of the day, it's their responsibility to make those changes.
Yes.
So those are the things that I like to point out because it's not just about the codes. It's not just about the
No.
authorization. It's about the
Yes.
coverage. And all those pieces go together. So you have to have somebody, at least one person, who's checking those things. Maybe it's the same person doing your coding. I say
Yeah.
most offices will do well with having a biller and a coder, even if they're not
Yeah.
certified, at least someone who knows what they're doing in that way.
Agreed.
Maybe you can't afford two people, but you have one person. Maybe you're a small office that you just need one person. But even
Yeah.
if you're a big office, do you need 10 coders? Can't. For me personally, I worked with 10 providers on my own. Personally,
Hmm.
I had 10 providers. I did all their authorizations. I coded. I billed all for all of them. That
You were
was
a busy
me.
girl.
I was, but I got it done, and I felt like it was efficient. But I think I was properly trained too, and I definitely knew where to go for the answers. So I encourage practices that are listening, office managers, even coders, thinking about your role. Don't just go into it saying, I'm just going to code all day. I'm just going to put codes in the computer. It's not
Right.
what all you do. Um,
Right.
your goal is to get your provider paid, and that involves more than just entering a code in a computer. It's pretty important job.
Yes.
Um,
And not just getting paid, it's keeping paid,
oh
right?
yes, that's what
You
audits are
you
for,
can get
right?
paid for anything, it's keeping that money. Will it stand up to somebody looking at it? And that's also what
Exactly.
they have to be thinking about because that brings in that stuff about, using those products and doing things. You can do anything, you can bill for anything, but it's making sure that you're safeguarding that money in the future so you're not, because when they come to take it back, they're not gonna just want that money back. They're gonna want it, and they're gonna want interest, and then you can get into damages and fines and all that stuff to where it's not worth it. Due diligence up front, pays in dividends on the back end.
100%. And we're seeing the results of that right now. They call 2022 the year of the audit. We've done a lot of audits, not only on the oncology side, but other types of clinics and specialties. In my history, of course, I've done orthopedics, I've done ophthalmology in the past, and those are the types of specialties I thrive on. I love surgery personally. Some people
Yeah.
enjoy other types of services where they're audited very differently. And that's the other
Yeah.
thing too, is that when you're looking at a certain service line, you know that those procedures are audited a certain way. So in oncology, you have your infusion, radiation oncology, even surgical onc as well.
Yeah.
But in orthopedics or a surgical practice, you're looking at different things. I remember, when I did orthopedics for the hospital and I was auditing internally, there were so many indications that the coders were just looking at that procedure description and they were not reading the op note paragraph.
Yeah.
It was obvious because one point he said he did a debridement to the bone. There was no evidence of that in the body of the note. I can't give you a 1-1, a 0-1-2, a 1-2 if you didn't tell me the bone was involved, right? So
Yep.
those are the things that we catch. Um, and it's a matter of just talking to the provider. They may have done it, but that communication from their brain to the paper or to the EMR did not happen for some
Yep.
reason.
A lot of
What are your
times that's what
recommendations
they
for
thought they were
conversations
going to
about
do,
this?
you know?
Yeah.
Yeah.
What
Or
are your
I've had the
recommendations
cases to
for these
where
conversations?
they call it something, right, in the header,
Mhm.
and then you read the op report and you look at CPT and you're like, okay, well, you call it this, but that's not what CPTs call it, so you get that differentiation between the fact of, their kind of verbiage and what it falls under, and it just doesn't match up. I've had those conversations with physicians before that, yeah, well, that's not what they call it in CPT, or that's not where it works out to, So when you're doing the op reports, you have to read the whole operative report, you know, um, uh, because there's other things maybe that were added on that, again, because that's not where the physician was thinking he was going. And a lot of surgeons will dictate those first portions before they've done the surgery, and then they come back
Mhm.
and do the actual surgical report, and it goes down a different pathway, but they never go back up to the header and
Mhm.
change what that was supposed to be or the additional things they did. So a lot of times in op reports I'll find things that, well, you did this too, and you can report it and get paid for it, but if they're coding out of that header, they never see it.
Exactly. And it happens, and they're always asking you, we're looking for missed opportunities. Telling you what, those missed opportunities are there in the op note, but if your coders and billers aren't trained to properly code from the body of the op note, they are
Right.
missing those if they're the ones coding them.
Yep.
I would have my orthopedic surgeon, this is before EMRs. This is when I worked before the EMRs, hand you a piece of paper with the code on it. I had to go and try to get the report. They fax it to us at that point. They fax all the op notes for the day to our
Mhm.
office. I'd have
Yep.
to find the op note and look for it because my job was to make sure we didn't just code the knee replacement. Was there an additional service? Now, most of the time, that's all bundled, but I had to make
Yeah.
sure that
Yeah.
there wasn't anything that we could report separately. These are all things to keep in mind that you could be losing money not because of the insurance issues, not because the insurance denied something. You just
Right.
didn't code it correctly, and you're missing
Yep.
revenue because of that.
Yep.
You miss an opportunity here that is billable, and there's so many
Yep.
of those that exist that I think if practices really had auditors come in and identify those things, train their coders, provide ongoing education, then
Yep.
providers can still see their patients, focus on that, and the coders can feel more empowered and
Yeah.
more educated so they
Yeah.
can not miss those opportunities. And then you can increase your revenue that you wouldn't have increased normally without that review.
Definitely. Definitely. Yeah. You're not trying, and that's the other thing with doing the audits. The external audits. We're not trying to replace your staff.
No.
We're not trying to take that's we're there to take a look at your stuff as snapshot. They're there daily looking at the day-to-day stuff. So the more educated that they are and the more things that you can show them, here's the things you want to look for, the better they can help on an ongoing daily basis to where that stays that steady stream or that increased stream of catching those things that weren't being caught before.
Absolutely, Betty. Well, this has been fabulous. I'm very excited that we got to do this here today and have all of these discussions about auditing, internal, external, all the different types and why they're so important. And later this month, we'll have a next episode. I'll be joined by one of my colleagues, Manish Jain of OncoSpark, And we're going to talk about the prior authorization dilemma that we find ourselves in and how it
Oh,
relates to other areas of auditing and coding and all of these things. So thank you, Betty, for joining us for Healthcare Crossroads. And we hope to, of course, have you on the show again. And of course, we'll collaborate in the future. And I want to thank our audience for joining in for this episode 1 of season 1 of Healthcare Crossroads. Thank you. And until next time,
thanks. Thanks for having me. Bye bye.
bye bye.